Welcome back to the Art of Aging Well. I'm Dr. Bharat Desai. Now, quick disclaimer, this program is for health education only. It is not a personal medical advice, so please consult your physician before making any changes. Now, as many of you know, I have been obsessively talking about the pandemic of metabolic dysfunction, which is insulin resistance. It is a real pandemic, a modern plague, I have called it. The most destructive disease of our era. The hidden root cause of almost every chronic diseases we face today. But today, I'm going to diverge and going to talk about a very different kind of epidemic. It is also very important, but for the exact opposite reason. While the metabolic epidemic is real, underdiagnosed, and undertreated, the epidemic I'm going to discuss today is an illusion. It's not real. It is aggressively pursued, overdiagnosed, and overtreated. It's a man made crisis, engineered by bureaucrats and powerful interest to help fill their pockets. The contrast is striking. In metabolic dysfunction, the harm comes from the lack of early detection, prevention, and effective treatment. While in this epidemic, harm comes from aggressive surveillance and resulting treatment itself. So, what is this epidemic all about? Where we are told there is an explosion of fractures caused by osteoporosis. Specifically, the diagnosis of age-related osteoporosis, meaning thin bones, porous bones. It's ICD-10 code M81. Now, two critical questions must be asked. First, is this diagnosis truly a disease or it's just an invented manufactured diagnosis? And second, are women really breaking bones at epidemic rates? And that is exactly what we're going to examine today. But first, I want to thank my dear friend Pallavi Shah and dedicate this entire series on osteoporosis to her. If she hadn't asked me for a personal health advice a few months ago, I might never have fallen down the rabbit hole of osteoporosis. What I discovered is so disturbing and so alarming that it almost feels unreal. Even now, I find myself wondering, can this be true? How could this have happened? And after you watch this series, I'm sure you will be asking the same questions. And Pallavi has graciously agreed to join me in a later video and share her own story in her own words. What happened to her is a wake-up call, not just for patients and the doctors, but for all of us. So let's begin. Let's answer the first question. Is the age-related thinning of bone really a disease? Or is it as natural as losing hair or losing muscles? We don't call these things a disease unless the loss is truly abnormal. But then how do you define abnormal? Normally in medicine, you compare yourself to your peers, people your own age, sex, height, etc. And if your bone loss is substantially worse than your peers, then you can call it a disease. So then you ask, how much bone loss is abnormal, right? How do you know? How do you determine that? Well, Let's look at the history. Historically, osteoporosis was a diagnosis reserved for people who had already suffered fragility fractures, meaning fractures that happen with little or no trauma. But everything changed in 1994 when a World Health Organization (WHO) working group met in Geneva and created a brand new diagnosis, M81, the age-related bone loss. A new diagnosis was based on a T-score of minus 2.5 on DEXA, which measures your bone mineral density in the hip and spine and compares it to the peak bone density of a healthy 30-year-old Caucasian woman. So when a doctor tells you after the DEXA, oh, you have osteoporosis and you need treatment, are they really saying your bones are going to break easily from a small twist or a misstep more than someone your age? Or that your bones are thinning abnormally? And it's no. A T-score of minus 2.5 does not tell you any of that. Note that down. What it tells you is this, that your bones are thinner than those of a young woman at her peak. Whoop-de-doo. So what? You're not 30 anymore. You're going to have a thinning. So look at this table. It shows that fracture risk rises heavily with age, but not nearly as much as with T-score. So T-score is just one factor that can influence fracture risk, and not a very good one. As a matter of fact, the majority of fractures do not occur in people with T-score of minus 2.5 or worse. So a T-score does not measure quality, flexibility, or a true health of a bone. It only measures how thick it is, how much concrete is in there. But bone can be thick and brittle, or thinner and still strong and elastic. And this is why two women can have a same T-score. One breaks a hip while other never does. Unfortunately, patients and doctors become fixated on this number. If it goes up, they feel reassured and believe whatever they're doing or medication is working. But if it goes down, they become frightened and think they're going to break the bone anytime, any day. But this is totally misguided. Because a change in T-score does not reliably translate into a proportional change in whether you as an individual will fracture. So fracture risk is influenced by how old you are, how healthy and strong your bones are, and how likely you're going to fall. Not just how thick or thin the bones appear on the scan, right? Now Z-score, which compares your bone density to your own peers, is a far more logical measure, naturally, right? And likely more predictive of future fracture risk. So you would ask, well, how come we don't use that? Well, we tried, but it was intentionally rejected. I was really dismayed to find that many modern DEXA reports today don't even include the Z-score anymore. We used to have that Z-score before on the report, but not anymore. Now critics and the scientists at the time argued that using T-score was scientifically baseless, and they pleaded with WHO that please use Z-score instead and not T-score. But they were ignored. Why? Powerful interest and industry bias drowned out their voices. And by using T score, WHO effectively labeled a massive portion of aging women population as disease overnight and created a huge market for osteoporosis drugs. Under these rules, almost every woman who lives into her 80s will be labeled as having a disease by DEXA scan, even if she's perfectly healthy for her age. Now let's answer the second question. Are fractures really exploding? Is there an epidemic? You hear stories, right? A friend falls, a neighbor misses a step, or a relative twists an ankle and there is a break. And that's scary. You are frightened, right? Of course, it's going to frighten you. And you would think, am I going to be next? At the same time, you are also hearing very strong messages from major bone organizations, institutions. International Osteoporosis Foundation calls osteoporosis a global health crisis. And it says fractures are at epidemic proportions. Look at the words they are using, and warns of coming tsunami of fractures. In the United States, there is Bone Health and Osteoporosis Foundation, which is the main body, warns osteoporosis is vastly underdiagnosed and undertreated. And I will challenge it, overdiagnosed and overtreated. Millions of Americans are at risk, according to them. We must close the treatment gap because they just want treatment. Why? Both these institutions are heavily supported by drug companies like Amgen, Eli Lilly, Merck, Novartis, and Roche. They all produce osteoporosis drugs. So here you go. Money talks. All right. Let's move away from rhetoric and look at the reality. Look at the fact. Look at the data. Here is a graph. From roughly 1970 to about 2000, age-related hip fracture rates were already falling. Remember, they were falling. Some analyses show they were dropping about 3 to 4% a year. And here is what's crucial. This drop, this improvement started way before the first blockbuster osteoporosis drug, Fosamax, entered the market in mid-1990. By 2010, that drug had been available for about 15 years. And it had become a blockbuster therapy for osteoporosis in postmenopausal women. So now you ask, if it were truly effective, you should expect the decline in the fracture to accelerate. There should be more decline instead of 4%, right? But instead, after the early 2000, the rate of improvement stalled or slowed. And in some age groups, hip fractures even rose slightly. So naturally, you would say, what's wrong? What would you conclude? Number one, you will think perhaps there is no epidemic, no tsunami of fractures, right? Because rates are falling. And number two, you would think that the drug probably did not reduce the risk because it did not fall more. Actually, it rose somewhere and maybe even contributed to hip fractures, right? Well, you will be disappointed to hear the response from the medical establishment. We were told the problem was under treatment, that too many people stopped therapy because they were afraid of side effects. Listen to the afraid of side effects. Well, hello. Of course they were afraid. Of course they would stop. Wouldn't you, with these serious side effects like jaw necrosis, dental problem, dentists wouldn't even touch if you are on those drugs. Esophageal irritation, ulcers, and atypical fractures. Fractures. as a side effect of a treatment to prevent fractures. Now, this is illogical, right? And this illogical argument reminds me of an incident I had with a cardiologist few months back. He was bragging about statins after I gave a lecture. He says it's lifesaver, it's miracle drugs, it saved everything. So I said, simple question. If these drugs, statins, were so miraculous, why isn't coronary heart disease disappearing or reduced significantly? It's not, right? It's going up. And his answer floored me. He said, because not enough people are taking statins. Look at that logic. If things get better, the drug gets the credit. But if things don't get better, it's not the drugs are ineffective, we just need more of them. I mean, what kind of stupid logic is there, right? So when fractures rate stop improving, the response was not, hey, let's re-examine the model, maybe something is not right. Instead, it was more screening, more diagnosis, more fear, and more treatment. And the patient, you, trusting the system, the medical establishment, has been paying the price ever since. Not only financially, but with your health, with your bones. So let's recap. The fracture epidemic is an illusion, it's not real. And age-related bone loss, that's a diagnosis M81, is a normal biology, it's not a disease. T-score is not the best predictor of fracture risk. Age, nutrition, hormones, muscle strength, balance, physical stress on the bone, and the fall risk are far more important. So in the next video, we will address the following questions. If it's not the T-score, then what really predicts future risk, right? You would like to know, you would like to prevent fractures. And how should bone health actually be evaluated? Before we finish, I want to remind you again, please, this discussion is for health education only, because we'll be talking about drugs. So please do not stop or change any medication without discussing with your physician. My purpose is only to equip you with evidence-based knowledge so you can ask better questions and have a more honest conversation with your physician. Medicine talks a lot about informed consent. There are papers and papers, right? But real informed consent requires real information. Clear, balanced, and understandable. And that information is sadly often lacking in the modern medicine. If you found this information helpful, please subscribe and click the bell so you are notified when the new video is released. I'll be posting new videos on different topics, hopefully once a week. Share this with your friends, family, or anyone who might benefit. And leave a comment with your questions or thoughts. Thank you for watching. Stay healthy and stay curious. Until next time, goodbye.